Laurence Klotz to give us some insights on inclusion criteria in the active surveillance topic. And everybody knows Laurie, so I think there's no need to present him. We're looking forward to hear him. I've been skiing with him this morning, and he had great energy. He nearly ditched some of the companions with him, so, you know, let's see if he can keep with us for this lecture. Thanks so much, Laurie.
Thank you, Chris and Peter and Franz and Machi. And again, I just echo, it's really great to be here. Wonderful meeting. And so I'm just going to start with a case, and I ask you to raise your hand, even if you're not a urologist. And this is a typical kind of case that we see all the time, a 60-year-old male, no family history, 50 cc benign feeling prostate, and his PSA has gone from 6 to 8.5 over 2 years. You do a biopsy, Gleason 3+3 in 4 out of 12 cores, 10 to 30% of core involvement. So many options, shared patient decision making, but what would your most likely treatment be? Surgery, brachy, IMRT, active surveillance, or focal therapy? So if you just raise your hands. Surgery? Okay, that's probably half. Brachytherapy, do we have any radiation oncologists? 1. IMRT, same guy. Oops. Active surveillance. Okay, so there's a few, maybe 15%. And focal therapy? Okay. So there's a range. The era of active surveillance, we began our program in about 1996, and we had our first publication in 2002, which was considered fairly controversial at the time. So it's been a long story now, more than 15 years, and it's not really a new concept, but quite a bit has changed. Certainly greater recognition of the overtreatment problem. We've heard about that a lot today. No one disputes that anymore. Wider acceptance of surveillance, reduce the number needed to treat. Molecular characterization of Gleason pattern 3 compared to 4. Better understanding of the bad ones, the patients who have the occult high-grade cancers and how you find them early. New definition of clinically insignificant disease beyond the STAMI definition of 0.5 cc's of Gleason 6 or less, that a lot of the studies of expressing concern about these favorable risk patients having clinically significant disease were based on. The flaws of PSA kinetics, it's sensitive but not specific. I'll go into that a little bit. Multiparametric MRI, and the next 2 talks are going to be focusing on that, has an increasing role. Modeling studies demonstrating the robust nature of surveillance as compared to the anticipated mortality rate, and some data on the 5 ARIs. So, you know, it's a very active field. These are some concepts I hope we can agree on. And these, I would say, are not motherhood at all. That microfocal prostate cancer occurs normally with age, that Gleason pattern 3 has little or no metastatic potential, that higher volume Gleason 3 is associated with an increased risk of coexistent higher grade cancer. And that is the major significance of volume. Great debate about higher volume Gleason 3+3. That is the point, and I'll show some of that data. It's quite convincing. That there are some patients who have 3 plus a little bit of Gleason 4 who have indolent disease and probably could be managed conservatively. But the bad one is Gleason pattern 4 and 5. That's real cancer. We don't want to undertreat those patients. And that finally, imaging and targeted biopsies, we are just on the cusp of a revolution, and it's going to change things a lot. I just went to the end of the talk somehow. I don't know how I did that. I've never done that before. Okay. You just had the talk in reverse. Thank you very much. This is a fantastic article, 20th anniversary of New England Journal, 200 years of surgery by Atul Gawande. And the conclusion, he says, if the past quarter century has brought minimally invasive procedures, the next may bring the elimination of invasion. And we all know that many treatments that we use are headed in that direction. not just minimally invasive, but non-invasive, of course, active surveillance falls into that. I just want to emphasize at the start, it's hard to get an absolute consensus about indications and triggers, because my assignment was to discuss indications and triggers, because there are really two different approaches, and this is expressed in the eligibility requirements that different groups have had, and the triggers. So there's the inclusive approach, which I would say we have taken, include all low-risk patients. We don't operate on those people anymore, and some low to intermediate risk, and it's about half of new patients. About a third get treated, so about 35% avoid treatment. And our prostate cancer mortality, I'll show you some updated data, is about 3% at 15 years. Versus what could be called the Hopkins approach, which is to say we are unwilling to accept really any patients having an unnecessary death. We will be restrictive in our approach. So it's the Epstein criteria only, 1 or 2 cores, no more than half a core involved. It's about a fifth of new patients. You avoid overtreatment in 10 to 15%, and the aim is to have perhaps 1% prostate cancer mortality. It is never going to be 0, because one thing we've learned is there's a few patients diagnosed with low-risk cancer who harbor micrometastasis. It's the bad 1%, and that is not going to change. So, but how you feel about these things, the trade-off of quality of life versus that slight difference in mortality, is going to determine one's attitude. Just some basic reminders. The likelihood of harboring microfocal prostate cancer on biopsy is your age as a percentage. 30% of men in their 30s in this Detroit group, didn't matter about black or white. 40% in the 40s, 50%, 60%, 80%. I say this is part of the aging process. Men develop this as they get older. There's nothing abnormal about it. It occurs in all races and ethnicities. The other key point about this is if you're a man in your 40s and you're found to have a microfocus, is that always going to progress? The answer clearly is no. It can't possibly, because you can't have 40% of men in their 40s with microfocal disease and say they're going to progress. The mortality rate we know is low, not even a fraction of that. A second key point is the natural history of Gleason 6. So the conservative management studies, the famous Albertson paper of conservative management of prostate cancer, were limited by the fact that they did not have surgical pathology grading. So we know a third of these patients are undergraded. And of course, some of those are going to go on and progress and die. Amongst patients who have real Gleason 6, so they have their prostate taken out, and no evidence of higher grade cancer, the mortality in those patients from prostate cancer appears to be 0. I'm curious to know, does anyone here in the audience know of a patient who had a radical prostatectomy for Gleason 6 only, who went on to die of prostate cancer? Alex. Okay. Because I've asked this question at many audiences, and so far have not yet heard of a single well-documented case. It is certainly extremely low. There's 2 papers that confirm this. This is Eggener, 12,000 Gleason 6. In the paper it says 0.2% prostate cancer mortality. They re-reviewed those. They found elements of Gleason 4. One of the issues is, pathologists disagree about grading under some case. And then another similar paper, 14,000 Gleason 6s, 22 positive nodes, 22 patients with positive nodes. All of those had Gleason 4 on re-review. So 2 studies that really emphasize whether it's extremely low or 0 is probably not a critical point. It's close to 0. And one of the developments in this field over the last, say, 5 years is a much better understanding of the molecular characterization of Gleason 3 compared to 4. And if you line up, there are, according to a classic paper by Weinberg and Hanahan, 8 hallmarks of cancer, including things like angiogenesis, proliferation, and sensitivity to anti-growth signals, and so on. And we know the molecular pathways that characterize each of these hallmarks. So if you line these up, and you look at how the gene expression compares between 3 and 4, it is remarkable for almost all of them. They're normal or not aberrant in 3, they're aberrant in 4, overexpressed, absent if it's a tumor suppressor gene, mutated if it's an oncogene, etc. There's a few cases that don't fit into this, but by and large, most genes are normal in 3 and abnormal in 4. TMPRSS2-ERG is one of them. It's abnormal in about 20% of Gleason 3, and but by and large, it's remarkably consistent. Now, some of you may be thinking, come on, you know, biology is not black and white like that. There must be exceptions. And here is one of the amazing ones. This is just published, an N of 1 from Hopkins. A young guy, 47, surgery almost 20 years ago, 4+3 positive nodes. He died 17 years later, and they did a warm autopsy. So they resected every different metastatic site, liver, lung, bone all over the place, and prostate. And they did genome-wide sequencing. And the remarkable thing is that there was molecular homology or similarity between all of the metastases, which looked like they were monoclonal, and one microfocus of Gleason 6 in the prostate, a 3 millimeter microfocus of Gleason 6. That was, it looks like that had the same molecular characteristics as the metastasis. So what do you make of that? I would say 2 important points. One is, there is such a thing as pre-histologic genetic alterations in the prostate, where you can have genetic alterations and the cells still look relatively normal. There's really no doubt about that anymore, although that's not the norm, because otherwise Gleason score would not have the predictive power that it does. And the second point is that this is not a microfocus of 6 in a normal prostate. This is a microfocus of 6 in a prostate that is loaded with Gleason pattern 4, and that clearly is not the same phenomenon. So just to kind of keep the pot stirring, it's not a completely black and white story. And I think we can take all that information and develop a kind of a better model of prostate cancer development. This is kind of the traditional concept of low-grade to high-grade PIN to Gleason 3 to 4 and 5 to metastasis. This is probably almost certainly incorrect. What is much more likely is, like with bladder cancer, you have this bifurcated development of a proliferative type of cancer, which leads to Gleason 3 but does not metastasize, and a dysplastic growth pattern with a completely different molecular pathway, and higher Gleason grade cancer and metastasis. And once in a while, you get this. You get a biologic progression, and you hope a trigger for intervention at that point. But this doesn't happen very often. Now, one of the questions in the field is, how often does that happen? And it's something that people have grappled with. And this is our data. We have 1,000 patients now on surveillance, and we've done serial biopsies. So we looked at the likelihood of upgrading as a function of the time since the original biopsy. And in fact, there is a positive slope to that curve. So the longer, it starts at 20%. This is sampling. 20% were upgraded at the start, but then the likelihood increased over time at 1% a year. And the Hopkins group has come up with almost the identical data. So this leads to the conclusion that there is true biological progression, but it's uncommon. It means you've got to follow these patients long term. About 10% at 10 years will progress from 3 to 4, mostly those with high volume Gleason 3, but it's not a common phenomenon. So selection criteria, I mentioned there's different philosophies. We have taken basically all Gleason 6, PSA less than 10, PSA density. It's becoming increasingly clear that that is an important predictor for harboring higher grade cancer, which is a reflection of higher volume cancer and a smaller prostate. Other people have used the Epstein criteria, 2 or 3 cores, no more than 50% involvement. The Epstein group, which is, whoops, pardon me, The Epstein group, this is the Tosolian publication, have treated patients whenever they have more than Epstein criteria. Most people wait for higher grade cancer. So there's a range, but you can see there's also a lot of similarity. So I think today there's a consensus. If you have a, say, 65-year-old man with 1 microfocus of Gleason 6, fairly low PSA density, active surveillance at least should be offered to that patient. I think it's the treatment of choice. But what do you do with higher volume Gleason 6? And should we be treating everyone who has more than Epstein? Well, I think the evidence is very clear that the significance of higher volume Gleason 6 is that it predicts for an increased risk of higher grade cancer. I'll just show a few data sets. This is ours, that a higher number of cores predicted for a 2-fold greater risk of higher grade cancer. This is from Hopkins group. Down here, LR is low risk, that's D'Amico, all Gleason 6. VLR, very low risk, that's Epstein. Same thing, about a twofold increased risk of upgrading. And this is some very recent data that has been done by a Swedish group. I was a collaborator, that they found that the extent of cancer was a predictor for upgrading on biopsy with a same thing, about 1.7 to 2 times greater, with a threshold of about 8 millimeters. And I thought this is kind of interesting that the likelihood of upgrading, if you can identify the patients who have less than 8 millimeters and fewer than about a third of the biopsies being positive, the likelihood of upgrading was very low. So again, a way to identify patients who are at risk or not at risk. Progression criteria. So again, this is where philosophy comes in. We've been fairly lenient. They need to have a significant amount of 4. Everyone else uses grade above any Gleason 4, 3 plus 4. Another group that is more stringent wants significant amounts of Gleason 4. The Epstein group, more than 2 positive cores, too restrictive in my view, but it's a philosophical thing. And then several groups, including the Prius group, has used PSA doubling time or velocity. And these are our results. So these are the patients who've been treated after a period of observation. So you see about 40%, now going up to 20 years in some patients, have been treated. The curve flattens out after about 12 years. This is one of the problems with surveillance, in my opinion. This is the wrong shape of the curve. What we want is a curve that looks like this. We should find the bad ones right away, and then the curve should be very flat after that because we've identified the bad patients early. Now, I think the field is moving quickly, and with newer approaches, we're going to achieve this, but it just emphasizes that there's room for improvement. This is the Prius group published last year. Basically, the curve has exactly the same shape and almost the same percentage of patients being treated. They treated 20% of the patients that they treated were treated for a doubling time less than 3 years, about 9% for anxiety, which is roughly the same as our group. And most patients treated for upgrading, either Gleason score above 6, more than 2 cores, or the combination. The ideal trigger would identify the high-risk patients early, so we have not done such a good job of that. High negative predictive value, inexpensive, widely available, reproducible, preferably not tissue-based. A number of biomarkers have been approved by the FDA based on genetic analysis of tissue. And while the data looks fairly promising, I think many people believe too many biopsies is a problem and an unmet need. Having said that, PSA kinetics, which we used for the first decade of our program, which the Prius group, I believe, is still using, perhaps Dr. Schroeder can comment on that, it doesn't work. And the reason why is it's sensitive but not specific. We took the roughly 300 patients in our core group who were totally stable, no progression, no treatment, no metastasis. And we looked at how the PSA kinetics behaved. and it behaved badly. So half of patients, depending on how you calculated the doubling time, had a false trigger for intervention, and they had it on average 2 or 3 times. So you follow these patients, the PSA fluctuates fairly dramatically, you decide the doubling time is less than 3 years, and you overtreat the patient based on that. And this is a summary of this by Andrew Vickers a few years ago, all of the major papers on PSA kinetics and in localized prostate cancer, worse area under the curve, etc. Little evidence that pretreatment PSA velocity doubling time are of value for early stage prostate cancer. It does identify the bad patients, but it also identifies far too many favorable patients. This is our updated data. I know Dr. Schroeder has seen this because he referred to it earlier. This is just quite hot off the press. Now patients followed, some of them out to 20 years. And it's interesting, the last time we reported this, which was about 5 years ago, we had 5 deaths, and they were almost all of them early deaths, so micrometastasis prior to diagnosis. We are now getting some late deaths, and it's a little disconcerting because you can see here the patients followed more than about 12 years. We're starting to see some of these guys die of prostate cancer who presumably, had they been treated 12 or 14 years prior, would have been cured. And there's wide confidence limits here because the numbers are fairly small. 70 patients followed out to 14 years, and beyond that, it's really very small numbers. But it's a little bit of the phenomenon that many of the critics of surveillance predicted, which is if you follow these patients long enough, you're going to start to see them dying of prostate cancer. This still is less than 3% of the overall cohort. Again, this shows that there is room for improvement with how we manage patients on surveillance. I don't think it in any way undermines the basic concept. And this, to emphasize that, this was some modeling by Julia Hayes at Harvard of how high the mortality rate would have to be to outweigh the quality of life benefit. So the probability of prostate cancer-specific death against the quality of life utility, and this is probably where we are now with about a 3% prostate cancer mortality. And so you can see there's a lot of room to go with this modeling before you would say it's not worth it. It's too risky. Now, some areas where we can do it better. One is to expand the envelope so we include some intermediate risk patients with favorable disease, with indolent disease. This is a study that Alex Zlotta did, who of course is here in the audience. It's an autopsy study in Russians and Japanese where the prevalence of PSA screening was low, and it really confirmed the earlier results where prostate cancer prevalence was high, about 1/3 of patients overall at autopsy. These were undiagnosed men dying of other causes. But the remarkable thing is 1/2 of the patients who had prostate cancer had Gleason 7. 1/2 of the Asian, mostly Japanese, and about 30% of the Russians. So this, to some degree, goes against conventional wisdom. It says there's a lot of indolent, unsuspected Gleason 7 as well as Gleason 6. And it just emphasizes the point that we perhaps can include some of these patients with small amounts of Gleason 4. Another point I just want to emphasize is the overdiagnosis of Gleason 7. There's been grade inflation at a very high degree. It used to be that Gleason 7 was about 20%, and now it's gone up to about 2/3 of new diagnosis by some pathologists. And this is in part due to the redefinition of the Gleason scoring system in 2005 to include any higher grade cancer, even if it's an extremely tiny amount, is now included in the Gleason scoring system. Is Theo Vanderquast here? Yeah. Theo's here. Okay, Theo may take issue with what I'm saying, but this is my understanding. I think he agrees with this. And the problem is, you can imagine the big difference between Gleason 3 and 4 is Gleason 3 has a well-formed glandular structure with a lumen, and Gleason 4 has a very poorly defined lumen. And the problem is if you get tangential biopsy of a Gleason 3 acinus and you miss the lumen, the needle just misses it, then you'll see what you see here, which is very poorly formed or no lumen at all, and it looks to the pathologist like a Gleason 4. And the pathologist has to have the persistence to recognize this, go back to the block and look deeper and says, oh, there's a good lumen, it's a 3. But not everyone does this. And so it's estimated that about a quarter of cases may get overgraded because of this issue of tangential biopsy of a Gleason 3 acinus. Just something to be aware of, and just to show how much more common Gleason 7 has come. In this one study, which I think is German, went from a quarter of patients to more than 2/3 of patients just with this remodification. So it's something to be aware of, that not all Gleason 7 needs radical treatment, may be quite indolent. This is our data. We included about 20% with Gleason 7, mostly patients over 70. It did not predict for a likelihood of requiring treatment or progression. This is the UCSF data. The yellow line is intermediate risk, Gleason 7 or high PSA. The blue line is low risk. Actually, the intermediate risk patients did better in terms of the likelihood of requiring treatment. And another subset of patients that we probably should worry about some more are African American, African Canadians, I don't know what you call blacks in Europe, African Europeans, but certainly they have a different characteristic of cancer, and this was a study that just came from Hopkins, black versus white, much higher rate of occult higher grade cancers in the blacks than the whites. So that doesn't mean blacks shouldn't be offered surveillance, but you have to scrutinize them more carefully. You have to find those occult lesions. So some unanswered questions about triggers. Mark Emberton and I are going to talk later in this session about the role of MRI, so I've left that out. But what to do with the MRI lesion, because that's going to be an increasing problem. Do you biopsy it? Do you treat it? The whole biomarker story, that's also going to be in the next talk. The role of PSA kinetics, I addressed that. But can we do better? And going forward, do we integrate the new biomarkers with PSA kinetics, patient risk tolerance, disease volume? So it becomes a complex concatenation of factors, and it requires a good nomogram, which we don't really have at this point. So final slide, the future of this whole story. Screening is changing. We've heard a lot about that. MRI is going to be incorporated. We're going to be doing probably fewer biopsies. We're going to find fewer clinically insignificant cancer. We're going to have better biomarkers and imaging to find the bad actors early and change the shape of that curve of intervention so they get identified at the start. And then we're just looking for the very rare rate of biologic progression. We're going to include indolent variant of intermediate risk patients. And the goal, and Hartwig Hulen and I were talking about this at the break, what should the number needed to treat be? We should aim for a number needed to treat of 1, where we find the patient who's destined to die or have problems from the disease and treat him and not treat the rest. And that will require major advance in our ability to identify those patients. Thank you very much.
Well, Laurie, thanks a lot. It's been a rich talk. Any questions from the audience? Yes, please.
Hello, Gustafsson, Karolinska. As far as I remember, some of the criteria for cancer is that it should have an ability for infiltrative growth and disrespect for the organs limits locally. It should be able to metastasize, and it shall have a defect in the apoptosis program. None of this is present in what you presented, Gleason 3+3. Are you challenging the concept that Gleason 3+3 is a cancer, in fact?
Yeah, so actually it was, and there's much more to that story. So some of the markers I showed did include invasion, metastasis, apoptosis, angiogenesis. There's a fantastic article for any of you who are interested in molecular genetics of cancer called The Hallmarks of Cancer by Hanahan and Weinberg in Cell, updated in 2011. And there's a gorgeous article that Mark Emberton and Hash Ahmed wrote applying that specifically to prostate cancer. And there's several other articles out there that essentially make the same point, that if you look by and large at the molecular characteristics of Gleason 3, they look normal as judged by these hallmarks of cancer. So that is definitely your statement is correct, that I am challenging, and I'm not alone, because there's a number of people who are well informed, better than I in many cases about this, that Gleason 3 should either not be called cancer, or the term should be changed to something analogous to pun lump that we do for bladder. And there are opponents to that view. So this is a controversy in the field. And I know Theo Vanderquast has some views about this and might want to comment. In fact, he's probably giving a talk on it tomorrow. So yes, that is the short answer.
Well, then active surveillance should be a very good way to treat them then, if they are not cancers.
That's exactly the point I'm trying to make.
Yeah. Thanks.
But biology is not static. So you could say it's not a cancer today. It doesn't mean it's not going to be a cancer tomorrow.
No.
Which is why I have to follow.
But I mean, when you made repeat biopsies and a few of them were upgraded, that was maybe their primary cancer diagnosis, in fact, because it's a natural development over the years.
Right.
Yeah.
Right, but to that point, that's where imaging comes in, because there is sampling error. Yeah, but to that point, that's exactly where imaging comes in, because there is sampling error. We miss anterior tumors, and when you take Gleason's low-risk 6s to surgery, about a third will have higher grade. In the big MRI series, 32% had higher grade. So that is what drives so much overtreatment, the concern that you've missed something, especially in someone who's a little bit younger, who has low risk on the biopsy, because there's so much sampling error.
Laurie, I have a question for you. PSA kinetics, you're basically saying is useless, or close to being useless.
It's a flag, but it shouldn't be used alone as a trigger for intervention, notwithstanding that it was used as a trigger by us and by the Prius group for quite a while. But I think now the data is crystal clear that it is not specific enough, and you end up with overtreatment.
So therefore, if we've lost that as an ability, as a trigger, that puts us back in the biopsy realm. And I know you're about to talk about MRI. My question to you is, you didn't mention repeating biopsies as part of your ongoing surveillance strategy. And have you changed now that all subsequent biopsies are being triggered only by MRI, or do you still rebiopsy every 2 or 3 years?
So I deliberately divided this talk into two, because the other talk I'm giving later is on MRI as in surveillance. So it's got I think a major role, and whether it can replace the biopsy going forward is not known yet. We believe adamantly that everyone must have a second biopsy within a year of the first biopsy, targeting the areas of the prostate that are typically missed on the initial diagnostic biopsy. And then after that, we do it every 3 to 5 years, depending on age, comorbidity, PSA kinetics, PSA density, whether the patient had any Gleason 4 pattern in the earlier biopsies. So we haven't changed yet, but we do MRIs, not routinely, but in those patients in whom either they have bad PSA kinetics or volume increase or something doesn't seem right.
So why, if MRI is of growing importance, why has a baseline MRI 4 months after biopsy not become part of your standard to enroll someone in an active surveillance protocol?
Very simple, because in Canada we don't have access to the resources that would make that possible. So, but I think, I mean, I'm sure we're going to have this discussion. Who should have an MRI? I think it's a great test, and probably most people should have it.
I guess with that, we're going to have Mark Emberton come up and answer that. So Mark, Arnaud Villiers is not here, and as a substitute, Mark Emberton is going to talk about MRI fusion in prostate cancer imaging and diagnosis.